Welcome to the HPB Fellows Grand Rounds. Chaya from Toronto is going to be giving us a talk today about colorectal liver metastases, touching on some important controversies with some cases. And what we'll try to do is at various times interrupt her and have an opportunity to get feedback from different sites. If you're not actively talking, if you could mute yourself, that is helpful in terms of feedback across, because there's so many people who are logged into the video conference. And we will take call a little later. Here's Rohan is pulling up to the screen. Rohan, is it all right?
Hi there. How are you doing, Brendan?
Do you want to take a formal roll call, or do you want to let Jill do it in the background?
Yeah, why don't we let Jill do it in the background. Welcome everyone to our HPB Grand Rounds. I'm so sorry to be late. Our presenting site is the University of Toronto, and Dr. Visser has kindly agreed to be our moderator, and the topic is really interesting. It's metastatic colorectal cancer of the liver. So Jill, do you mind going through and giving us a roll call of everyone that's here, and also, if possible, giving us visual?
Well, I think I know the recall. Whether or not.
Sure, no problem. Do we have Ascension? Barnes Jewish? Carolinas, Atrium Health? Looks like Barnes Jewish is just getting on. Cleveland Clinic? Dalhousie? Duke's here. Indiana University, I see you're here. Mayo? I see you're here having trouble with your audio. Feel free to go ahead and call in with your telephone in the meantime while you're working on the computer audio. McGill? MD Anderson?
Here.
Memorial College or Medical College of Wisconsin? Memorial Sloan Kettering? Methodist? Terrence Jackson?
Yes, here.
Okay, great. Oregon, I have both Lauren and Victor. Providence, Portland, is Emilio and John, are you both on? Stanford,
Yes, we are.
John. Toronto.
Yeah, we do.
Great. Just send me a chat with who's here from Toronto. That would be great. Cleveland. University of Louisville, I urge to have both of you on. Pittsburgh, Samir Tomei. Okay. Virginia Mason, we have Morgan Bonds. Is Russell available? And George.
Russell is here.
Okay, great. And lastly, from Washington, Teresa and Susie from WashU. Looks like Barnes Jewish, WashU are together. Just send me a chat of who's here. All ready to roll. Thanks.
Okay, Chaya, you're on.
Okay, Brendan, let me hand it over to you.
We're all here. Tracy, Susie, and Sankit, three fellows.
You're right here.
Got it.
All right, folks, let's let Chaya get started with her slides. And then, as I said, if you are not actively participating at the moment, if you could mute yourself temporarily, that would be super helpful.
Okay, so my name is Chaya Schwartz. Nice to see you all here. And I'm going to talk about colorectal liver metastasis. I decided to talk about this subject because I think we're all going to encounter patients that have colorectal liver mets, and we're going to have many areas of debate that we can discuss in this talk. Okay, so as you can see, a lot of subjects that we can look into in this in colorectal liver metastasis. However, we only have an hour, so I decided to focus on a few subjects: the timing of surgery, the role of ablation, PV if we have time, and then liver transplantation. So the first thing that we talk about when we talk about colorectal liver mets as surgeons is we ask ourselves is that a resectable disease or not? So the definition of resectable disease changed over the years. So for example, the number and size of the liver metastases are no longer a contraindication for resection. And I think the three main conditions that we should have and think about before we're moving forward to surgery are: one, if we're going to have a clean margin after resection; second, if we're going to have sufficient remnant liver that the patient is not going to get into liver insufficiency; and of course adequate inflow and outflow after the procedure. And if the patient has bad prognostic factors, we should probably think twice about surgery. I'm not saying that we should not perform surgery, but we should think twice about what we're going to do and how aggressive we're going to be. For example, no response for chemotherapy, or unresectable or unstable disease extrahepatic, or very high level of CEA that are not responding to chemo. So these, you can see here on the left, the traditional criteria for colorectal liver metastasis that used to be, for example, like you have to have fewer than 4 lesions. Now it's no longer a limit, and the rest of the stuff as well, including vascular invasion, that we can do vascular reconstruction. So it's something that's changed over the years. So this slide, I really like this slide. So when we look at bilateral colorectal liver metastasis, I think this slide gives you kind of a perspective about the different surgery that different procedures that we can do. So mainly in the beginning, you look at the right side of the liver and decide if the metastasis are on the peripheral of the right side or on the central of the right side of the liver. When you look at the right peripheral metastasis, if you have also metastasis in the periphery of the left side, you can do a parenchyma-preserving hepatectomy at the same procedure. If you have right peripheral and left central disease, you can do left hepatectomy and then clean the right side with a bunch of wedge resections. And then if you look at the right central metastasis on the right side of the chart, you'll see that if you have right central disease and left peripheral, you may be worried about not having enough volume after the procedure, and you should think about two-stage hepatectomy with PVE. And as you can see here, the left liver is growing after the PVE. And also, if you have a small limited metastasis on the left side of the liver, you can use ablation. We'll talk about it a little bit later in the talk. And then if you have many metastases all over the liver, you can think about infusion pump that we're not going to discuss today, or liver transplant that we're going to talk at the end of this talk today. So we'll start with the first case presentation. This is a 65-year-old male patient, very fit and in a good shape, and he had routine screening for a fecal occult blood test that was positive. He was completely asymptomatic, had colonoscopy that showed tumor in the cecum, and then CT scan of the chest, abdomen, and pelvis that showed bilateral liver disease. The patient, so here we can see on the CT scan the disease of the metastasis in the liver. You can see bilateral disease, and I'll show you, he also has a disease on the caudate lobe. And then there was one tumor that we were more worried about, and I'll show you. Here you can see the proximity to the porta. So when we saw this patient, we were thinking about this lesion. We decided to move forward to surgery.
Can I interrupt you there, Chaya, for a minute? And then Morgan, are you there from Virginia Mason? Morgan, are you there?
I haven't been for these adjuvant. No.
I'm looking for Virginia Mason on the line. There you go. Oh, you're muted. Oh, we got to unmute you.
I haven't been muted.
There you go. Are you back? Morgan?
Yes.
Okay, so looking at this scan, this patient referred to you. What are your initial thoughts here? What would you start with before Chaya tells us what they did?
So I must have missed, do we know where the primary tumor is? The cecum. Okay, so this is a right-sided tumor. It has, the liver tumors are pretty large, and that one that's really close to the portal vein would be difficult to resect up front. So I think for this patient, they're at low risk of obstruction. I mean, you can do the colon first and then start chemotherapy, but I think this patient would benefit from upfront neoadjuvant chemotherapy.
Okay, I think that's a really sensible approach. Chaya, how did you guys approach this?
So this patient is not, at this point, he was not presented to us yet. So the patient was deemed non-resectable liver-wise in the hospital. They got right hemicolectomy with T3 and 1 on pathology, received 10 cycles of chemotherapy, and then presented for us for evaluation for surgery of the liver. We did an MRI on the patient that showed basically the same lesions on the same spots that we saw before. And then we proceeded, we decided to actually move forward for surgery after performing, checking the volumes of the patient. So as you can see here on the left, we included on the left side the resection, we included the left side of the liver with the caudate lobe, as well as we resected this tumor on segment 6. And still the patient, you can see here, on the upper part of the slide, that the patient had enough volume to be left after surgery, so we decided to proceed with liver resection. So what we did in surgery was
let me interrupt you and see about other sites' thought. That's a lot of metastases. Remind us, how much chemotherapy had the patient had before you took him to the operating room? I'm sorry? Okay. Maybe Tim, you're there from MD Anderson?
Hey, yeah, this is Tim.
Yeah, so you're at a center with lots of experience at doing multiple metastasectomies and combinations of resection and ablation. Did you have a chance to see this pattern of disease?
Do we see this pattern of disease? Yes, of course.
So can you comment on thoughts about an approach for this?
Yeah, so I think that the important thing to talk about with this patient up front is whether they have obstructive symptoms and how imminent you think their potential for obstruction is from their primary tumor before thinking about whether to do any type of neoadjuvant therapy. Our bias is a liver-first approach, and we typically like to give systemic chemotherapy prior to a liver-first surgery approach if we can. But obviously, if the patient's symptomatic, then that's a different story. It doesn't sound like this patient was symptomatic, so we would favor an upfront systemic therapy. We typically start with 4 to 6 cycles of chemotherapy with restaging, and then decide upon resectability. We like to avoid longer than that if we can, depending on their response to chemo, biomarker trending, and things like that, as well as the extent of the planned surgery because of trying to avoid chemotherapy-associated liver injury.
Yeah, this is a super challenging case that Chaya is showing us because it's probably could be deemed borderline from the get-go. Chaya, how much reduction in the size of these Mets did you guys get from your 10 cycles of chemo?
Not a lot, but it was stable disease, so it did not advance at all. But I remind you that the patient was, everything happened before he got here. So he only transferred to us for the liver evaluation.
But so you had plateaued in terms of response well.
Yeah.
Okay, well show us what you did. I mean, this is a very complex resection here.
Yeah, and I'll talk a little bit about liver first and everything, you know, in a few minutes. But this is what we did. We did extended left hepatectomy and a wedge resection of segment 6. We also did intraoperative cholangiogram just to make sure we did not injure the right duct. And this is some pictures from the operating room. As you can see, the surface of the liver when we did the left hepatectomy and the resection from segment 6. Then moving forward. So now I want to talk a little bit about how do we evaluate the future liver remnant, and I think there are some independent predictors of post-hepatectomy liver failure. Some of them are related to the patient, like what's the volume and function of the FLR that we're going to talk about it in a few minutes, and then liver related if the patient had or did not have chemotherapy and how many cycles and which chemotherapy. Some of the chemotherapies can injure the liver more than others. And then also surgery-related factors is the patient is going to have adequate inflow, outflow, as well as biliary drainage. So when we talk about evaluation of the FLR, we talk first about volume. So in a patient with a relatively healthy liver with fewer cycles, we will want the patient to have at least 20% of the liver after the procedure. However, in a patient that received many cycles of chemotherapy, most of us will prefer to have larger size of the liver remain after surgery. Obviously, the risks for the major complications after surgery, if the patient has less than 20% of the total volume, are higher than if the patient will have more volume. And then when we move forward to talk about the function of the liver, so we can talk about work, like blood work, we can talk about hepatobiliary scans, but I think nobody does, like most of the people don't do scans anymore. So I decided to focus on ICG. So when we talk about ICG is a water-soluble anionic compound that is usually connected to proteins in the blood right after, a couple of minutes after IV administration, and then excreted through the liver. And then we can kind of pretty easily measure the, I'll show you here. You can see this is how we do it. The patient is like we inject a 0.5 milligram per kilogram of ICG in a fast push, and as well as after that flashing it. And then we wait for 15 minutes to see how much excretion from the liver was. And we see it on a small screen, like you can see here on the side. A small screen that will show us the ICG plasma disappearance rate. So the ICG plasma disappearance rate, if the plasma disappearance rate is more than 50%, we know that we're pretty much safe to do a large resection. However, if it's less than 7%, we should be worried about the function of the liver after performing the resection. I do want to say that most of the research that was done about ICG came from the Far East. I'm talking about HCC, and we're here dealing with colorectal liver metastasis, which is obviously different than HCC, and the injury to the liver by chemotherapy is also a different, something very different from people with HCC and cirrhosis. So this is something that we still need to look into it when we talk about colorectal liver mets. It may be less accurate than in other diseases.
Let me interrupt you there, Chaya. So
Yes.
I think there's a lot of background noise, folks. Those people, I think it may be people who are on cell phones calling in who haven't muted themselves. So if you could be kind enough to do so that we can hear Chaya. So I want to ask two questions here. One is are there other centers that are using routine volumetrics for complex resection? So not just what is the volume of a left lateral segment, which our radiologists could give you segment 2 and 3, but are there other centers who are routinely using 3D recons with sort of resectional planning software, aka like in the old Pathfinder days, is number one. And are there any other centers that are using ICG that have this? I mean, it's been reported for a long time. I've not been at a center that was using it routinely, and I was wondering if any other centers beyond Toronto are doing so. Anybody can speak up with experience, or either Chaya is the expert on the line.
I will just say that we're not doing ICG here in Toronto, but yet, like someone is like whispering in my ear. Like I will say that we're at my back home program, we use that to all the patients. So 100% of the patients get the ICG, but it's only in the past, I would say probably a year and a half. So I can't say yet, like I don't have data yet that will say if it's good or not for colorectal liver mets. That's it. But
Any other centers?
For everyone.
Any other centers that are using ICG or 3D recons routinely?
Brendan, so we don't do the ICG, but we do measure everybody who's going to have a major resection like this with reconstruction, not necessarily a 3D, but they do a sum of discs method, but CT volumetry. And, you know, there's 20%, 30% data that I've shown in the previous slide. Most of us are using kind of a 30% because the 20% data, FLR data, is for people with a normal liver. As you and I know, I mean, there's less and less Americans with a normal liver. And if you add in any kind of chemo, 6 cycles or less, or 6 cycles or more, usually 20% is not going to be enough for most American patients. So 30% based on our own data is the safest. That reduces the chance for post-operative hepatic insufficiency and almost eliminates the chance of post-op liver failure death.
Yeah. And so, but do your radiologists do complex volumemetry or just what's the left lateral segment because I'm going to do a right trisect?
So we tell them exactly what segments to measure that we're going to leave behind, like we're going to do an extended left or an extended right or just a right. And then they give us the cubic centimeters. I can share the spreadsheet with y'all. Cubic centimeters for the whole liver, and then standardized to the body surface area. And then we calculate based on that. Also, we make them subtract out the tumor. So that's key. You got a 6 centimeter tumor in your remnant, and that because it's going to be part of your first stage, you need to subtract that out because that's not a liver that you're going to be able to use. So in fact, if you do a first stage hepatectomy, we will do an immediate CT on the table because we have a hybrid room. We do the surgery we We do a dynamic CT immediately to see the amount of liver left over, and then they do the PVE in the hybrid room. But that way you know exactly what you're starting with before your PVE, so you can measure your KGR.
Yeah. So I think that's great. I think it's worthwhile for all the fellows on the phone, though, to realize, because when you go to a conference, you see a beautiful 3D recon that is somebody is doing, which is done on occasion, but not commonly. And most, of the highest volume centers are on the phone right now. And yet, in terms of sort of preoperative planning software for complex bilobar resections, not being used very routinely, and no other centers using FLR. So that means that most of the highest volume centers in the United States are still basically relying on surgeons licking their finger, putting it in the air, and eyeballing which way the wind is blowing. So I think that's really important for this group of trainees and surgeons to realize that that is what your colleagues are doing, and that perhaps there's room for improvement among all of us in terms of figuring out if these technologies are really going to change the curve for hepatic failure. Please. Yeah.
This is just briefly. I think what was said kind of summarizes it nicely. What we have the issue is that we rely on our radiologists to do this. So we have the software, and we're able to do similar to what MD Anderson was describing, especially removing the tumors itself, which we think is very helpful, especially when it's very large. But in terms of do we do it on a routine basis, we really only do it when basically it looks to us like there's going to be way too much liver resected. So basically when we're concerned. So it's kind of as needed, if you will.
Yeah. All right, great. Hi, keep going. This is terrific.
Just one point that my colleagues, fellows, are sitting here, all of them, and I want to say that we are actually doing the volumes ourselves here. So I think if you have the software, it's something that you can, like, we teach each other, so the second year's fellows are teaching us the first year's fellows, and I think if you have the software, you can master it pretty quickly. So the next subject we're going to talk about is resectable colorectal liver mets. The 2 points I'm going to mention is the timing of resection, and the second one is ablation. So when we talk about like the timing of resection, we have the classic or bowel first, and then meaning that we're going to remove the primary tumor, and then usually chemotherapy, and then after a few months we'll do resection of the liver mets, like the patient that we just presented. We can have combined approach with the synchronous resection of both primary and liver mets, and liver first, which is chemotherapy usually in the beginning, and then removal of the liver metastasis, and then later on removal of the primary tumor. Obviously, there are advantages and disadvantages to each one. If we'll do the combined approach, the patient will have one anesthetic and one post-operative timing. And then also, however, we are not letting the tumor to define its biology. If we do the liver first, we give the patient chemotherapy or chemoradiation if we're talking about rectum. And then we do the liver first, and then we're going to resect the primary later. So we're kind of like optimizing the resectability of the tumor, and also we have earlier control of the liver disease. And so there was a very recent paper from Europe that showed that 72% of the patients in the last few years are having synchronous resection, and 14% of the patient has liver first resection. However, when you look into the details of the paper, you can see that in the last couple of years of the study, liver first is becoming, like one of you guys mentioned a few minutes ago, the liver first is becoming more and more common. I am going to mention something that was interesting in this paper, that they showed that like programs that have HPV surgeons are more doing combined and liver first when compared to different hospitals that they don't have HPV surgeons, and they will do the primary first more commonly. And when they looked at the patients in the different groups, in the liver first group, there were more patients with rectal cancer. On the combined group, there were more patients with colon cancer, as well as smaller metastasis in the periphery of the liver. So it would have been more easier to do at the same time, and less risk of insufficiency after the procedure. Then later on, they looked at survival, and they showed that there was no difference in survival between the two groups. So you can see here that they compared both liver first to bowel first, as well as simultaneous to bowel first, and they showed no difference after propensity score and before propensity score. Just a second. Okay. So now when we talk about a different paper that from a French group, they compared the primary first versus liver first. They did not mention at all the simultaneous liver and the primary resection. They had 653 patients in total. 90% of them had primary first, and then 10% had liver first. And then they looked at, again, at survival, and the overall survival there was no difference in overall survival between the two groups. However, the recurrent-free survival was worse in the patients that had liver first group. But when they looked at, they did a propensity score analysis, then they found no significant difference between the two groups in any of these overall survival, recurrence-free survival, and recurrence at any site and intrahepatic recurrence. So they concluded that there is similar oncological outcomes. So now, as you can see here, there was no difference between the group after the propensity score analysis. Now moving on a little bit to talk about ablation. So I think this is something that was very, very interesting to me when I prepared this talk, because ablation is always something that as surgeons, we always think, I mean, at least, like we always think that resection is maybe better and maybe we're not doing good for the patients. So I'm going to start with presenting a case, and then we'll discuss a little bit more the ablation, and if you can use ablation in our OR. So this is a 54-year-old female patient with a history of prior T3N0 rectal cancer with synchronous liver metastasis. She was treated initially with diverting loop colostomy and right hepatectomy, plus resection of wedge resection of segment 3. She was followed by chemoradiation for rectal cancer and low arterial resection after that. She completed a total of 12 cycles of FOLFIRI and Avastin, and then when she had the surveillance imaging, she had recurrence of disease in the liver. As you can see here, she has a tumor here on segment 3, as well as tumor here very in close proximity to the left hepatic vein. So what we did laparotomy, we did segment 3 liver resection, as well as microwave ablation to the segment 2 mass, and then reversed the ostomy, and she did very well. So now we're going to talk a little bit about ablation. So, yes.
Sorry, I think I was temporarily muted because we were trying to. Jill was kindly trying to control the background noise, and I want to get into your microwave ablation, but we hadn't had a chance to stop and talk a little bit about the question of synchronous combined resections versus stage resections and liver first approach. So in the first case, maybe we can get another center. Newhook was telling us that at MD Anderson, they would have favored giving some chemotherapy and then perhaps a liver first approach. Looks like Barnes Jewish is there. Sanket, are you there? Are you the fellow? Can we get a sense for what you guys would do there? So that was the initial patient with the right colon cancer and bilobar metastases.
Yeah, can you hear me?
Yeah.
I think that was looking like quite a complex resection, so that's not one we do it synchronously on. So it would depend on how symptomatic the patient was from this right-sided cancer, if it's a cecal cancer causing bowel obstruction or if it's obstructing. Otherwise, it'd be chemotherapy, a period of observation, and then figure out the strategy. But otherwise, I'd support what was done there, which is to take the bowel out first, then chemotherapy to test the disease biology, etc.
And how do you decide about the different kinds of colon, right? What I'm getting at is the right versus left, those that are going to be lap versus open.
Yeah, so I have this sort of worked out in my mind, and it's probably a hybrid of some of the places that people have learned from, which is that it'd be much more comfortable combining a right colonic resection, just think it's a joint that's less likely to leak, with a liver resection. So probably a rectal cancer or something like that would be unusual even here to make that a synchronous resection. And then as far as the liver is concerned, again, it would depend on what sort of liver resection. So, a wedge resection, sure. A hepatectomy, a left-sided, left lateral section, still fine. 2 days ago, we did a right and a right, and that was fine. But it's just a case-by-case basis is probably the easiest way to put it.
Okay. I mean, I think that's a good way to try to summarize it. It's about the risk of the colon resection and the magnitude of the liver resection. I would say at Stanford, we are probably relatively aggressive about trying to do combined resections where it's feasible. I think that what is not calculated into these survival curves, which can be impactful, is the difference for the patient. If you can do it safely, the difference for a patient for an operation, a one-off operation that addresses both, is quite a bit different from 2 operations, whichever one you've done first, as long as it can be safe. I think we underestimate that importance, the psychological importance for patients. But I think that was a good way to summarize it in terms of the magnitude of the liver and the risk of the colon for leaking. Okay. Other thoughts or insights from other sites?
Brendan, this is Adnan again. I guess my question is more about these images that we're talking about ablation. If that's okay, I know that's a change in topic.
Sure.
But,
well,
so
Haya's going to go ahead and tell us what they did. If you want to let her go first, and then I can come back to you, Adnan.
Sure.
There's
Want to do that?
just one thing from our side, that there's a question that that we wanted to ask. If whoever do synchronous resection, do you guys do ileostomy for all these patients or no?
Great question. I can give my answer. Other sites can weigh in here.
Maybe I'll jump in, Brendan. So I think we may be one of the few sites that does our own colon resections over here, so we're a little bit unusual. We tend to do liver first at our center, and I think, as was said by Wash Yu, there are many factors that go into this: the extent of liver resection, the extent, the lower or left-sidedness of the colon resection, rectal, etc., sequencing in of radiation in the appropriate patient with rectal cancer when they're off systemic management too, because they'll just be getting 5FU as opposed to good systemic coverage if they've got a rectal cancer, etc. And then, of course, the patient themselves, as far as their ability to tolerate 2 major procedures at the same time and tolerate, we would do the liver first, obviously, because of low CVP anesthesia. If it's a rectal cancer and they've received radiation, we would do a diverting loop ileostomy in the synchronous case. If it's a right and a right or a right and a left, we would just anastomose in that case, as long as there was no hypotension or anything at our center, Kaya.
Okay, thank you.
Yeah, I think another thing that for the fellows to think about is technical approaches and access based on patient's body size. So there are patients who are small and not very big, where with a midline incision, you can do a right hepatectomy and their left colectomy in the same patient. They're going to have good liver remnant, and that access will be absolutely adequate. But if you're going to end up making a reverse L for your hepatectomy and then need some access to colon resection, that can be challenging also. So all of those elements go into it as well. So I think those are great points. Okay, Hayat, now coming back to this recurrent case, why don't you keep moving forward and tell us what you did for this complex recurrence?
Okay.
Brendan?
Yeah.
Yeah, this is Rob Martin, University of Louisville. Just your synopsis is very well stated, but I also want to throw in for the fellows that, obviously doing these laparoscopically has allowed us to minimize that type of incision length that you are mentioning because of either doing both or at least one of the index operations laparoscopically, so you avoid that stem to stern or significant kind of long incision that I think you were alluding to with your second.
Yeah, I absolutely agree with you. But there also, and then there's another consideration in terms of technical approach I was just sort of only briefly touching on, which is a combined lap resection can be a very long operation. So that's another consideration when you think, okay, how much surgery, how many hours am I going to subject this patient to? So lap versus open, access, body habitus, male or female pelvis for some of these patients, all those things are all part of this really complex decision making. Absolutely agree. Okay, Haya.
So going back to this patient, what we did was laparotomy segment 3 liver resection. We microwaved the segment 2 lesion that was close to the left hepatic vein. And then reversal of the loop ileostomy, and she recovered from the procedure very well. So now talking a little bit about ablation. So we as surgeons, we always say that the gold standard for colorectal liver metastasis is always surgery, but in 50% of the patient at least, the surgical resection with negative margin cannot be reached. And then we need to think about sometimes about ablation, and I'll show some data about the subject. So in 2015, there was a position paper from a group of experts in ablation. Most of them were IR people, but some of them were also surgeons. And they were talking in this position paper, they were not talking about resectable disease, they were talking about patients with technically inoperable but limited disease, or also patients that had too many comorbidities that they will not take the surgery, like they're not going to go into surgery because of their comorbidities. What they want to emphasize in this paper that tumors that are larger than 5 centimeters, we should not try to ablate because the rate of incomplete ablation rate and recurrence rate, local recurrence rate were very, very high. So their recommendation was when we want to use this technique, we should use it for tumors for sure less than 5, but then later on less than 3 centimeters. But they only talked about patients that are not resectable. Later on, this is a paper that was published after the first one. They took 53 resectable colorectal liver metastases, compared liver resection with ablation. And this, they showed that there was no difference in 1, 3, and 5-year survival rates. However, they showed that the recurrence-free survival rates were different between the two groups, as you can see in the Kaplan-Meier graph here on the side. And they concluded that the liver resection has greater efficacy than the ablation. However, when you look, and then this one is a meta-analysis that showed exactly the same, that liver resection is better than ablation. However, when you look at other papers, they show exactly the opposite. They show that there is no difference, so it's very not clear, and obviously we don't have any randomized controlled trial yet to show that there is no difference or there is a difference for one of the groups. Then we now talk about a paper that is dealing with a combined intraoperative resection, like combined intraoperative ablation and resection, comparing the combined resection to hepatectomy alone. And this paper, they showed that hepatectomy, there was no difference in the survival between the two groups, not overall survival and not disease-free survival, and there is no difference in intrahepatic and extrahepatic recurrence. They did show that there was 30% of local recurrence at the ablated side. There was no difference in local recurrence at the liver cut surface between the groups, because in both groups, one group was only hepatectomy and the other was hepatectomy with ablation. And they did show the overall local recurrence was higher in the combined group. However, there was no difference in intrahepatic disease-free survival. So this paper, their conclusion was that hepatectomy and RFA achieved outcomes comparable to hepatectomy alone, and they actually advised to use ablation when we can, and they were talking about cure. So I think the main issue with ablation is that we don't have enough good trials talking about this subject. So this is a trial that already listed in trials, so maybe we'll get some answers from this one. Now, moving on to the next subject is what are we going to...
Let me interrupt you again.
No problem.
So, Adnan, you had a comment on this recent case and this recurrent disease.
No, my comment was, sorry, I think I assumed that we were moving on with that case, and that those 2 lesions were ablated, which I thought would, obviously one of those is on a pedicle, on the umbilical pedicle.
Got it. Okay.
That's what I'm trying to point out, that's all.
Okay, but I think that both of the first 2 cases, or both that complex resection, bilobar resection, and this recurrent case, raise a really important point in terms of, or question in terms of planning these resections. So, John Gary, are you there in Providence? Unmute John Gary. So my question here is, both of these cases have really problematic margins. I'd say even with the what proved to be a safe bilobar resection on that first case, and then this recurrence where there's tumor that is up against the left hepatic vein, which is the only hepatic vein left. Whatever they did, you're not getting a lot of margin. So what is an adequate margin, John Gary?
With colorectal mets, negative margin.
A negative margin. How are you defining negative?
Microscopic negative margin. I want to say I remember seeing a paper that showed margin lengths of 2 centimeters, 1 centimeter, less than 1 centimeter. I want to say their survival curves, disease-free survival curves, were similar as long as they had a microscopic negative margin. But obviously, you know, we shoot for at least a 1 centimeter margin.
All right. Okay, so let's get some other voices in here. So Russell at Virginia Mason, I'm threw both of your fellows under the bus here, and since he texted me that my fellows are here to make sure that I called on both of you. So Morgan and Russell, you're both getting called on. So at Virginia Mason, what's an adequate margin for colorectal liver mets? And then we'll get somebody with more professorial status after you.
Okay, well, I'm definitely here. I think depending on margin status, we look at the molecular pattern from the original tumor, and in fact, it's KRAS status.
Explain, sorry. Your KRAS status is going to tell you what we need for margin when you're planning your hepatectomy?
Yeah, so for KRAS wild types, we'd want to have ideally a 1 centimeter margin. Or excuse me, for mutants, we'd want to have a 1 centimeter margin, whereas for wild type, it would be a microscopically negative margin.
Huh, teach me. Maybe one of your faculty can chime in here and help, because this is not something that I have differentiated on, and I don't know if maybe perhaps everybody else is, but I'm not. So teach me.
Well, we certainly, this is Flavio, Brendan. I don't expect to be the world's expert on KRAS status and resection of colorectal liver mets. There's plenty of other sites that have some data regarding that. But what I would say is that I'm a little, I guess, disappointed that we've had 3 cases presented here of colorectal liver metastases, and not one of them has had any biomarker profiles mentioned. So either KRAS status, MMR status, or BRAF status. Because I think what we're learning more and more is that the biology of this disease makes a big difference. And so there have been some retrospective studies regarding margin length and KRAS status. And so that, yes, in the KRAS wild mutant types, the margin status needs to be a little bit longer for that. Whether it's 1 centimeter, whether it's, you know, greater than 1 centimeter is not been exactly determined. But we do know that biology makes a difference here.
Flavio, just clarify the question, which is that, are you going to plan your resection based on KRAS status?
I think I'm going to plan a lot of things besides my resection. So even at the beginning, I'm gonna plan my chemotherapy status, my chemotherapy regimen, depending on the KRAS status and also on the tumor sidedness. So, for example, that first case with the right-sided tumor is probably, if it was a KRAS wild type, would not benefit from any panitumumab or cetuximab, because the data has shown from multiple trials that actually does not add anything else to their downstaging potential. So yes, I think for KRAS mutants, I'm very worried about a patient that has multiple liver mets in that scenario, and I'm going to want to be a little bit, if I'm going to operate on those patients, be a little more aggressive with the margins.
And if I could add, like there's at least 2 series, one out of MD Anderson, which they're on the phone, that basically shows that if you're a KRAS mutant, your recurrence rate is almost 100% if you have actually close margins. And so much an argument for that really parenchymal preserving may not be the ideal case for patients with double hit, whether it's KRAS and or with P53. And so those patients, they may be unresectable from the get-go, even if we technically can resect them.
Right, which is they have worse disease across the board. Right. I think it's still hard to know exactly how to apply that in practice to resection. To me.
Well, I'm wondering, is Chinwei still on? Does he have any comment?
Yeah, so a lot of people use the KRAS data as a veto, but we do not use it as a veto. We use it to temper our expectation. So if somebody's KRAS wild type, you can expect a 60% 5-year survival on average. While if you are KRAS mutant, 30% 5-year survival if you were to group the two clumps, separate. So that's a huge difference just offhand. Does that mean we don't offer surgery to KRAS mutant patients? Of course not. If they have a good response to chemotherapy, their CEA comes down, and they're resectable, of course you're going to give them a chance. But the reason we use KRAS is in those borderline situations, borderline biology, where we can help temper the realistic expectations of relapse in the future. In regards to the size of the margin, the paper that most people are referencing is that we looked at the microsatellite mets around the resection. Around most liver mets is around 4 millimeters, while if you have a KRAS tumor, it's about 7 millimeters. This means that the microsatellites extend a little bit further from each tumor. And so, yeah, maybe you try for a larger extent of surgery, but I think it's like melanoma surgery. Yeah, you want a 1 centimeter margin or a 2 centimeter margin, but if your tumor, your melanoma is next to your eyelid, you have to take what you can. So that's where the R1 vascular goes into play, which we haven't discussed. That's a whole other issue to talk about, the R1 vascular.
Okay, I think there's some great insights and honestly a lot of meat for further investigation and thought from everybody in the group. Okay, Chaya, why don't you go through this next case?
There was also a paper in 2016 Annals of Surgical Oncology that showed that R1 resection, when talking about vascular, is the same, like they have the same results. It's different than having R1 resection in the parenchyma, but I'm just like was in 2016, I think. But I did not, and about like I wanted to talk about many other things, but I didn't have enough time and not to give my witness, but I had to take a lot of time off. So I'm not going to talk about KRAS and mutations and all this, even if it's very important. So now the next, should I move forward, or you want to?
Yeah, I think move forward. We got 12 more minutes, so I think you can get through the next topic as well. Thank you.
Okay, so transplant or it doesn't matter. Okay, so this is a 75-year-old male patient with a 2-year history of intermittent bloody stools. On colonoscopy, he had a mid-rectal adenocarcinoma. The staging was negative for distant metastasis. He underwent neoadjuvant chemoradiation for the rectal tumor, and then he was presented in a tumor board. The recommendation was to continue with chemotherapy, and then restage the patient after 6 months. When we restaged the patient, the disease looked stable with a right-sided predominance of disease, as you can see here. I'll show you quickly so we can talk about this. So when we looked at in the beginning of my talk, I showed like a graph showing the different locations of the tumor. So you can see here that most of the disease is on the right side, and this patient had a few metastases on the left side. So with this patient, what we decided to do is we planned for right hepatectomy and wedge on the left side. However, when we did the volumes for the patient, it was only 28%. So the patient underwent PV to the right side with hypertrophy of the left side, and the new FLR was 40%, and we moved forward for surgery. This is how the liver looked like after the portal vein embolization. And we did a right hepatectomy with weight rejection of segment 2 and 4A. I'm just going to skip this. So when we talk about unresectable colorectal liver metastasis, we have a few things to offer. I'm only going to focus today. I mean, we don't have a lot of time left, but I was about to talk about PV and also liver transplantation. I'm sure one of my colleagues will speak about ALPS in a different talk. So when we talk about PVEs, so we talk about patients with bilateral colorectal liver metastasis that we suspect that they're going to have a small FLR after the procedure. So then we will think about 2-stage hepatectomy. We'll do the PVE to stimulate the hypertrophy of usually the left side. And then this approach usually generates a 30% of increase in the FLR size between 1 to 2 months. Usually here in Toronto General, we do a CT scan after 3 to 4 weeks to see what was the increase in the volume of the left side. Obviously, because we need to wait so long, 30% of the patient will not get the second procedure. Like we will not get a hepatectomy because of advanced disease, like progression of the disease while we're waiting for the liver to grow. So I know everyone knows everything about PV, so I wanted to mention something a little bit different. So hepatic and portal vein embolization. I think that this is something that is not very commonly done, but some of the patients will not have enough hypertrophy of the left side to get the resection. So one of the things that we can do is hepatic and portal vein embolization together. This is a systematic review that included 68 patients. To be honest, only 17 of the patients were having a colorectal liver met. Most of the patients had cholangiocarcinoma. And all these hepatic vein and portal vein embolization were performed very successfully. The patient did not have major complications after and not a mortality. The hypertrophy was about between 30 to 60%, and 40% of the patients remained unsuitable for resection because of not sufficient hypertrophy of the left liver or tumor progression. And I think it's so in this paper that we show here, some of the patients had the PV and then after a few weeks had the hepatic vein embolization and then moved forward to liver resection. Some of them had hepatic vein embolization and portal vein embolization at the same procedure and then move forward to liver resection. Obviously, the advantage of doing both at the same time is that the liver gets bigger much faster, and they're going to have it in the same procedure, so you don't need to wait. And if you do it in two procedures, so most of the people that are doing this, which is not a lot, if you see that the patient is doing well after portal vein embolization and not getting to insufficiency, you can move forward to hepatic vein embolization. Their conclusion, or our conclusion, was that hepatic and portal vein embolization as a preparation for major hepatectomy is feasible and safe, and could increase the resectability of patients that we in the beginning said are not resectable. Yes.
Can I just, because we only have a few more minutes, and you guys have some interesting insight, can I get you to just give a couple of slides about, because I think I agree that we have most centers have portal vein embo and some have hepatic vein embo experience, but can you jump to your transplant case?
Sure.
And because that's something that's not accessible to most centers.
No problem at all. So I'll quickly show that this is a 45-year-old patient that had synchronous rectosigmoid tumor with colorectal liver metastasis. She had resection of the primary tumor and hepatic artery infusion pump insertion that we're obviously not going to talk about today. You can see here that she has multiple tumors both sides of the liver, and we talked in the beginning of the talk, we showed the graph that talking about this situation when you have bilateral disease with many, many, many small tumors. And this patient had liver transplant on May 2019, and we saw her recently in the clinic and she had no evidence of disease. I'm just going to say this is a very recent paper that was published in Annals of Surgery that looked into 15 cases of liver transplant. I am going to say that they learned from the previous paper that came from Oslo, the SICA-1, and they showed that, I'll get to the conclusion or what they were thinking about. When they looked at the conclusion from the SICA-1 and said that the prognostic factors are extremely important. So when we take a patient for transplant, we have to look at the prognostic factors and not take patients with bad prognostic factors. And that, by the way, that includes KRAS mutation, obviously, and it's also in our list of patients for inclusion criteria for our study. So this is our protocol here that we're using neoadjuvant chemotherapy and living donor liver transplant for non-resectable colorectal liver metastasis. Obviously, we want to look at the survival and disease-free survival of these patients. This is the scheme of the study. So basically, we stop the chemotherapy 4 weeks before the transplant, and then our goal is to have 5 patients to follow them, and if we will have good results, to move forward to 20 patients. And I'm just going to say, show this consult chart very quickly. But basically, we assess patients that have colorectal liver metastasis are not resectable and that we think that can be suitable for the study. And then after we get all the inclusion criteria because there's a long list that I'm not going to show you now. We had 2 patients that had liver transplant. One of them, unfortunately, had metastatic disease to the lungs, but the other one is the one I just presented. Some of the other people that we enrolled into the study, they did not receive the liver because some of them had progression of disease. One became resectable, and one was did not have a living donor. So,
can I interrupt you there? So maybe Dr. Orloff at OHSU, I can see you're on the line. Can you give us a comment about what in the United States would be the eligibility with UNOS criteria? Is any center doing this as a research protocol?
Yeah, well, the University of Rochester just started doing these, and they use either live donor or they use less than optimal donors that other centers won't use. And so they've done so far 5 of them. The reason I know this is because my brother's at this program. But to get UNOS exception point would be difficult because we have a national review board, and that's not one of the criteria for getting MELD exception. So, you'd have to have a biologic or a laboratory MELD that was high enough that would allow you to get an organ in a timely fashion, albeit, again, live donor can be used for anyone if you have a live donor liver transplant program. But the numbers are so small, so I think the jury's not out. Most of these are done in the Netherlands and in France and other European countries where they have more organs.
And what is their best reported outcomes that you know of? Or maybe Chaya, if you have, I know you guys have just begun your experience, but is this the best that's out there?
Here, you can see, can you see this slide now?
Yeah,
so,
okay.
This is from the analogs of surgery. So the overall survival for these patients that they are transplanted was 1, 3, and 5 years was 183%, 83%. Disease-free survival, you can see here, 53, 44, and 35%. So I think they had very good results. They also compared between the form criteria between the better prognostic to the worst prognostic between the patient that they had on the group, and they show a difference between these 2. And do you want to add something?
I mean,
Dr. Potosachin is here. He can.
Yeah, I mean, I think one of the interesting things about the Oslo data is that they obviously are very aggressive with recurrences. So that's why the no evidence of disease in these patients is around 65% at 5 years. They've been, I mean, the most frequent site of recurrence in this setting is lung, and they've been very aggressive about treating the lung mets first with chemo and then resecting them.
Yeah, I think the other thing, in terms of the transplant community and outcomes, in terms of overall survival, if your intervention at 5 years gives you a more than 60% survival, then that mode of intervention, i.e. a transplant, is considered acceptable. And so if you look at the data, all small numbers, then it is an acceptable treatment. It's just that in the U.S., we really are fraught with not having enough organs, and so it's a really ethical thing who you're going to choose, and that's where live donor is probably the best way to start in most programs.
Yeah, and Susan, we have the same problem as in Toronto, and that's why we're using live donors.
Mm-hmm. I think it's a fascinating area for research, and ultimately, obviously, faced with challenges of organ availability, but may change how we approach this disease. So I think we're pretty much down to the last minute. Any other last comments or questions? I'm very grateful to every site for participating. We shall say gracias and obrigado because we have lots of different centers calling in today. Last minute thoughts or send-offs? Chaya, thank you very much. Obviously, an incredibly complex topic with lots of different and intriguing controversies. So thank you for your work.
Thank you very much for your help.
All right. Thank you so much. Joel, what's our next talk in December?
Even our
are you guys going to get credit for your
Jill, who's doing December?
We got the cookie. So in December, we will be moving December 4th. Atrium Health will be moderating and University of Calgary will be presenting. Topic TBD. We'll be in touch by email. Thanks, everybody.
Thank you so much, everyone, for joining. Thanks, Brendan.
When you get a chance, can you get that to